Hi, everyone. We're really excited and looking forward to the conversation on teaching patient management in the age of AI. As many of you are seeing, AI tools are becoming more capable at generating diagnoses. But in clinical practice, diagnosis is only the beginning. The more complex challenge is deciding how to manage a patient in context. That includes how we prioritize tests and treatments and how we weigh competing risks and how we adapt decisions to the realities of patient care. For educators and program leaders, this raises an important question. How do we teach and assess those management decisions in a way that reflects real clinical practice? And that's what today's session is focused on. With that, let's get into the discussion. I'm pleased to introduce our speakers today. First, we have Dr. Andrew Parsons, Associate Professor of Medicine and Associate Dean for Clinical Competency at the University of Virginia School of Medicine. Andrew's work focuses on clinical reasoning, especially management reasoning, and how we coach learners through complex clinical decisions. He leads the Clinical Reasoning Research Collaborative at UVA and is actively involved in research on how AI is being applied in real clinical settings. He's the author of Clinical Reasoning, Coaching, and Struggling Medical Learner, and brings a deep perspective on how trainees develop clinical judgment over time. We're really looking forward to hearing his insights today. And joining him is Dr. Ben Muller, Chief Content Officer at Sketchy. Ben oversees content across both Sketchy's core learning platform and DDX by Sketchy, and has spent several years working at the intersection of clinical education and instructional design. His work focuses on translating complex medical concepts into practical, engaging learning experiences that reflect how clinicians actually think and make decisions in practice. And with that, just a quick session details before we get started. The session is being recorded, so we'll be able to share the recording as well as the slides afterward for anyone who wants to revisit the content or share it with colleagues. Please feel free to submit questions at any time using the Q&A feature. We've set aside time at the end of the session for Q&A, where we'll address as many questions as we can. And just to set some expectations, our timing, we'll have about 45 minutes of presentation, followed by around 15 minutes of discussion. And with that, I'll turn it over to Dr. Parsons to get us started.
All right, thank you, Hillary, and thank you to the Sketchy and DDX team for having me. I'm excited to talk about this topic of beyond diagnosis, teaching patient management in the age of AI. So for many of us, I know the typical image of a physician is this master diagnostician, the clinician who sees what no one else can see and names the disease and solves the diagnostic mystery. This is particularly true for my specialty of internal medicine. And though we don't all become master diagnosticians, of course, the goal of medical education has long been focused on knowledge accumulation with the end goal of kind of effective diagnosis, effective diagnostic reasoning. We even began to teach clinical reasoning more explicitly over the past 15 or so years. And that is most of the time is diagnostic reasoning. So today I want to consider how our clinical reasoning education needs to change in a world increasingly shaped by artificial intelligence. So I'm going to begin with two threats posed by artificial intelligence, and I'll say that I'm being a bit provocative here on purpose. The first threat is displacement. As AI systems improve at diagnostic tasks, they threaten the identity we've built around clinical expertise as physicians, as clinicians. So if the expert diagnostician is our aspirational model and a machine can do that work, then what does that mean for how we define our role, for how we do our standard work? The other threat, the second threat, is descaling, and you may be familiar with that. That was addressed in some detail at a previous DDX webinar, but that's our growing reliance on AI tools and how that reliance can lead to cognitive offloading. So our trainees stop building their own reasoning abilities because the tool provides the answer for them. For me, the best practical example of this is GPS navigation in my car. I used to know where I'm going and be able to describe directions. Now I'm totally reliant on that GPS tool. So how real are these threats? Let me dive into the evidence for you. These are two recent studies that I want to highlight that illustrate the scope of AI diagnostic performance. On the left, you see a study I was involved in by Go and colleagues from JAMA Network Open a couple years ago now. They studied 50 clinicians and their performance on complex diagnostic tasks and found that the LLM alone, or the AI alone, scored 16 points higher than physicians who were working with conventional resources. So that could be anything like UpToDate, even Google, anything that they wanted to use. When they gave physicians access to the LLM, it improved their efficiency in getting to the right answer, but did not improve their diagnostic accuracy. The LLM was already performing at or above the level physicians could reach on their own. On the right, you see a study from Brodeur and colleagues. This is currently in preprint, but about to be published. And what they describe is superhuman LLM performance across 6 different experiments involving hundreds of physicians. This was a more recent model of ChatGPT. This used O1, which is a more reasoning model, a chain of thought model, and it had a median score of 97% on complex diagnostic cases compared to 74% for clinicians alone. So there's a lot of nuances here, right? A lot of details that we could go into, but these numbers are real. And so the displacement is not hypothetical. And we know that LLMs continue to improve at a big pace. Now, this slide explains why the data I just showed you should not necessarily surprise us. It draws on a recent piece in The Lancet by Adam Rodman and Eric Topol, as well as Pat Croscary's famous dual process theory that you may be familiar with. So on the left, we have expert cognition. How do expert physicians make decisions? Well, we know that they categorize clinical features almost instantaneously when they're confronted with clinical data, and they sort through the information and they form recognizable patterns. This is system one thinking that you may be familiar with. It's intuitive. It's built on years of study, thousands of patient encounters, and it's pattern recognition that allows the clinician to kind of perceive a gestalt, right? An intuition about a constellation of findings. Then they calibrate that. Does that fit the pattern that they have in their mind, or does it not? So this is that system two, more analytical check. On the right, we have how LLMs make decisions or how they think. You see, I have that in quotes. This is a token prediction system, and we don't have to go into the details of that, but the model predicts the most probable next word given everything preceding it. So it's trained on an enormous corpora of medical text, and the model develops learned statistical associations between the clinical features and the diagnoses. And more recent models have chain of thought reasoning, which is where they produce a step-by-step output, and you can really see their thinking. That's more in line with that system two type of reasoning. But the point of this comparison is that the two columns are doing fundamentally similar things. Both are pattern matching based to some degree on probability. Both draw on large volumes of prior cases, whether that's stored in illness scripts for the humans or whether that's on training data. The mechanisms are slightly different, but the cognitive task is the same, and that's the match the presentation of the patient to a known pattern and apply a diagnostic label to that. So perhaps it shouldn't be too surprising that LLMs, that AI is continually kind of reaching that threshold of human performance and may perhaps pass it. So we can think of that as quite a threat, and we can enact different strategies to combat potential de-skilling. And I think, many are already thinking about that. But we can also think about this as an opportunity, I'll say, to upskill in a specific area. And that specific area is management reasoning. Management reasoning is the other domain of clinical reasoning. The much less covered, receive much less attention in the literature and in our educational systems. Management reasoning was defined by Cook and colleagues back in 2018 as the process of making decisions about treatment, further testing, monitoring, follow-up visits, and our allocation of limited resources. In a recent JGIM paper, we argued that management reasoning deserves much more attention, especially in the age of AI. And there are reasons to think that only humans can do management reasoning well. So let me show you why I think that might be the case. So this slide compares management reasoning with diagnostic reasoning. I think we all kind of intuitively understand diagnostic reasoning more, so this is a helpful comparison. They're two different cognitive tasks. Diagnosis is a task of categorization. I just kind of explained that to you in terms of pattern matching, taking signs and symptoms. Does it fit the pattern or does it not? Management, in many ways, is more complex from that because it's a task of prioritization, meaning, regardless of the diagnosis, that doesn't necessarily equate to a set management plan, right? There are many different answers. It depends, and I'll talk about that more in a minute. But the fundamental task of management is prioritizing among multiple defensible options that you have and choosing one that is most appropriate for the patient and for the context. So it's highly contextual. And unlike diagnosis, which of course, a lot of time in the clinical environment we do along with the patient, we also do diagnostic reasoning on multiple choice questions and in many different ways independent from the patient. Whereas management reasoning requires communication. And it's ongoing, it's fluid, it's this dynamic interplay of multiple competing factors. Whereas on diagnosis, I like to say you either have pneumonia or you don't, right? It may take us a while to get to that answer, but you do or you don't. At the end of the day, our management can depend. So many usually say if we're focused on management, aren't there guidelines for that, right? Isn't there evidence for that? Well, guidelines are necessary for effective management reasoning, but not sufficient. If management requires the kind of nuanced, context-dependent reasoning that we just talked about, we can't be reliant just on the guidelines. And here's four reasons I can explain to you why, based on four different studies. So you see in the first here that 77% of real patients would have been excluded from trials that these guidelines are based on, right? So there's not kind of this one-to-one pattern matching from the trial to our patient, which I think we know well. This was demonstrated across 300 or so trials, so extensive data set. Next, about half of the strong recommendations you see in clinical practice guidelines are based on low quality evidence. And there's a 17-year average lag from evidence generation to routine clinical practice. And when cases get complex, even expert physicians will follow the guidelines only 56% of the time. That's what you see here on the right. And importantly, this is not deviation, by accident. This is deliberate tailoring to the patient. It's not an error. And experienced clinicians deviate intentionally when contextual factors demand it. We know novices deviate less, not because they are more guideline adherent in a more sophisticated way, but because they lack the experience to know when the guidelines fit and when they don't fit. Now, I mentioned that it depends. That's almost always the answer to a proposed management plan, which is it depends. You can have the same diagnosis and you can have different management. Here are two patients, Maria and Robert. Let's say both are 72, both have heart failure. Same diagnosis, same evidence base, but let's look at how the management might be different. So Maria wants to attend her granddaughter's wedding. That's her priority. So her management is going to be symptom focused, right? Flexible diuresis, perhaps, close outpatient follow-up, a plan designed around making it to that wedding, feeling well enough to be present and active in the wedding. Whereas Robert wants to maximize his woodworking capacity. That's his hobby. And he'll tolerate side effects if it means more functional output. So his management is aggressive optimization, pushing medications harder, accepting the trade-offs that Maria would not accept. So this is really the essence here of management reasoning. The diagnosis gives you a starting point, but the plan depends on who the patient is, what they value, and what their life actually looks like. So what do our trainees themselves think about management reasoning? Well, we conducted a study, a qualitative study using focus groups with 28 senior residents across 4 specialties at 2 academic medical centers. And I want to show you 3 themes that that emerged from this work. The first is that our trainees see management reasoning as linked to diagnosis, but distinct. As one resident put it, management is something that the patient can actually see or experience or feel. They recognize that getting the right diagnosis does not automatically mean what you need to do next, as we just explained. The cognitive work is different. They described it as pragmatic, as action-oriented, and as provisional, continually open to revision. Second, they conceptualize management reasoning as uncertain and risky. So unlike diagnosis, where there's often a right answer, management decisions involve trade-offs and consequences that can play out over time. So one said it does break down the idea that there's one right answer to the multiple choice question. And trainees found this to be intellectually taxing, to be emotionally taxing as well. And third, they recognize the context specificity, which we've talked about. As one resident put it, depending on what services are available or time of day, that shapes what's actually doable. And so you can see the institution, there's institution-specific culture, institution-specific practices, the team, what the patient values, acuity, cost, all shape the management plan. So in a similar study, we looked at what the developmental trajectory of management reasoning is from medical school to residency. So, and context is a huge issue here. Early on, our learners tend to be rigid and binary. They follow protocols. They think in terms of right and wrong answers, and they're generally risk averse. This is the kind of expected at the novice stage. But as they gain more experience managing real patients, we see this gradual shift. They move toward a more flexible and nuanced approach where they become more patient-centered in their reasoning, they become more comfortable with gray areas and are more context aware. So you can see here at the bottom, kind of moving from this protocol following to option weighing to contextual adaptation form of management. This trajectory really matters because, as you may be thinking now, our curricula are not set up in this way. They don't reflect this. And yet we know that much of what trainees do on a day-to-day basis is management. Now, before we talk about solutions, I want to show you what they described as the barriers to the development of their management reasoning. So you can see here, minimized responsibility was a huge one. So they felt many times they're enacting others' plans and they didn't have autonomy. So that would limit their ownership and their learning. There was a hierarchy when their plans would be overwritten without explanation. That was the key aspect there. Lack of continuity, right? They couldn't see what the effects of their management plan. There was lack of timely repetition, so kind of infrequent with cases or variability of cases, low variability would limit the formation of their scripts. Resource abundance was an interesting thing that came out of this. So over-testing, the ability to over-test without thinking twice, kind of replace their nuanced reasoning. And then just the fact that most of their didactics, specifically case conferences and such, were focused on diagnostic reasoning. And they thought that management reasoning was taught ad hoc way, if at all. So with that background, how should we teach management reasoning in the age of AI? So this slide lays out 4 core concepts that I think form the foundation of management reasoning. First is the management script. That's the mental schema of possible interventions for a clinical problem or a diagnosis. I'll talk to you more about that in a minute. But we use something called a management script template to teach this. The second is diagnostic uncertainty, then risk thresholds, and then finally shared decision. These are 4 concepts that are essential if we're going to upskill management reasoning. So I've mentioned management scripts a couple times. You may be familiar with the illness script, which is that stored medical knowledge. It's personal to each of us. It usually includes risk factors, pathophysiology, and how a disease might present, the signs and symptoms. So the idea being, if you have the knowledge stored in this effective way, that you can pattern match, as we talked about earlier. Well, there's an analogy to the illness script. That's the management script. It's also personal stored knowledge, but it's action oriented. So you see here, it's the various actions you could take based on a clinical problem, whether that's medications, procedures, monitoring, labs, imaging, consults, etc. This is what the management reasoning process looks like. Note that this is somewhat oversimplified, but this has been optimized for educational purposes. So starting left to right, you can see we're beginning with a working diagnosis, or we might be just a representation of the problem. We're then activating our management script. I want to emphasize here, we activate this in an illness specific way. Then based on a number of influencing contextual factors, we would select from our management script. So I'll play this out in an example in a minute, and then we'll enact that plan and we'll monitor and adjust it over time. So two core kind of processes here, the management script activation and the management option selection. First being illness specific and the second being context specific. So let me give you an example. And this is in the form of a management script template, which I would highly recommend you use as kind of a framework for your teaching and that learners use for their own learning. So you see I've got the categories of action, the different categories or buckets for the management script up and down the left-hand side. And once you've arrived at a working diagnosis or a prioritized differential, you want to build out your menu. This is all the options for all the options for the given diagnosis. So let's take something like acute pancreatitis, right? We don't have to go into the details of there, but here's all the things that we could do in each of these buckets for someone that we're concerned that they have acute pancreatitis. You have to really know the menu before you can pick off the menu. So, but then what are we actually going to do for this patient? That's what's over on the right in the selection box. That is where we bring in all of these influencing factors. So this comes from one of the studies I mentioned earlier. This is from the focus group study of trainees, and these were all the influencing factors that they have identified that impact their management reasoning. And so you see there's a number of them, but they're in big buckets here. I think intervention factors are something that we commonly focus on, right? What's the guidelines? What's the evidence? What's the risk of what we're doing? There's the cost, but then there's patient factors, right? Their own goals, values, beliefs. There's case-specific factors. What's the trajectory? What's the severity? What's the acuity? How certain are we that it's acute pancreatitis, right? That will broaden our menu. And then look at all the provider factors that are at play here. These are the things that we probably undervalue, under recognize, right? There's our own risk tolerance, our own comfort for uncertainty, our own emotional factors, biases, of course, familiarity with the patient, familiarity with the disease. And then we have things like institution-specific practices, systems constraints, legal risk, and feasibility. So think of this is your teaching menu, right? This is your language of management reasoning of all the factors that inform why you want to do something for managing a patient or why you might not. So you take this and you apply that to your menu on the left, and then you have what you're actually going to do for the patient on the right. And so when a learner may come and say, well, why are we doing this for one patient with pneumonia and then doing something totally different for another patient with the exact same diagnosis? You now have that language here that you can pull from to explain your rationale and to think out. So that's the management script template. I want to pull out a couple things which I showed you on that menu, mainly uncertainty and risk, because I think these are kind of key aspects of management, and they're also undertaught aspects. So here you see kind of a threshold. There's a test threshold. There's a treatment threshold. So for a test threshold, below a certain probability of disease, the risk of testing exceeds the benefit. So you do not test. Then the treatment threshold, above a certain probability, the benefit of treatment clearly outweighs the risk, so you treat. And between them lies this zone of uncertainty. That's what you see here in the yellow, where all the influencing factors we just discussed come into play. This is where the teaching occurs. This is where most of our clinical care occurs. We know that based on learner level, this yellow zone either shrinks in or expands out. So our trainees often struggle here, and they often pursue this uncertainty by ordering every test or calling every consult, or they avoid the decisions altogether, deferring to someone more senior. So we need to teach the calibration aspect here. So how do we assess uncertainty, name it explicitly, and make a reasonable decision despite that uncertainty? And now here we need to talk about risk as well as uncertainty. And I think we have to think about risk in a more in-depth way. So we tend to default to what I call like the technical lens of risk, which is assuming it can be quantitative, that we can actually say, here's the probability of harm, here's the magnitude of harm. Think about side effect profiles or number needed to harm or complication rates. That matters for sure, but is not the whole picture because risk is also very much perceived, right? It's shaped by our biases, by our lived experience, individual tolerance for risk. And so patients and clinicians do not evaluate risk objectively. And then you have a social and anthropological lens where risk is socially constructed. It's shaped by the relationships, by power dynamics, by the team culture, right? So all of this is going into risk perceptions, and all three lenses are operating simultaneously. So we have to think and teach risk in that way. Let me give you an example of how that might play out, because this leads us into shared decision making, which for purposes of management reasoning, I think we should really frame shared decision making as kind of risk calibration. It's understanding the risk concerns, risk tolerance of ourselves, of our patient, of our team, and bringing those together. So here you see a clinical example. Let's say a patient has CTPA and they're confirmed to have a low risk pulmonary embolism, low risk based on the PESI score, which you may be familiar with, right? So it's low risk, we can just discharge, right? That's what the trainee says. They take the technical lens of risk and they say, here's the 1.1% 30-day mortality. We can put them on a DOAC, we can discharge them. That's concordant with the guidelines. But then the patient says, well, wait, I've got a clot in my lung and you want to send me home? My friend said that PEs are deadly. I want to be admitted. Then the attending comes along and says, well, I agree with what you're saying here in terms of the PESI class 1, but we don't really discharge PEs here. I've seen them decompensate overnight. So this is the availability bias coming into play. And so shared decision making for purposes of management reasoning is really about reconciling competing perspectives. And so I'll wrap up here with kind of a unifying slide about management reasoning in GME. This slide brings everything together into a practical framework, and it organizes recommendations along two dimensions. So we've got an individual row at the top, and then we've got a program level row at the bottom. So at the individual level, on the experiential side, learners need to observe varied practice styles. They need to apply guidelines to actual patients in real contexts, engage in management decisions with patients and teams, and we have to give them, and they have to take genuine ownership over their patient care decisions. On the structured side, they need reflective practice. And this is really what they identified, the trainees identified in our studies as how they learn management reasoning. So that's asking the why behind management decisions. That also means we have to give them the why behind management decisions. And hopefully that language of influencing factors I showed you will help us do that. They need to seek out feedback, reflect on their missteps, and review patient charts to see the outcomes of their management decisions. At the program or institutional level, on the experiential side, the clinical environment, we have to structure it so that we foster this graduated autonomy and create situations that promote autonomous decision making, because that's really how we learn the nuances of management. So we need to explicitly discuss it during rounds. We need to ensure case repetition and variety. And then on the structured side, we just need to teach it more explicitly. So I gave you the management script template, which is a great way of teaching management reasoning in my humble opinion. We need to explicitly break this up into illness specific and I think context specific or patient specific management, and employ different frameworks. There's frameworks around how to navigate uncertainty around risk thresholds, which I just showed you, and shared decision making, and utilize our case-based conferences to not just be about getting to the right diagnosis, but to highlight contextual factors that were at play and why we chose this one nuance plan versus another to teach management reasoning. So with that, I'll just summarize the key takeaways from this talk before handing it over to Ben. First is AI closes the diagnostic gap. I think management reasoning can be our next educational frontier. And I think this just brings up things we should have been teaching more all along. If we want to upskill in this area, it requires experiential learning as well as structured teaching. Shared decision making, uncertainty navigation, and risk calibration are core management reasoning skills. And then we should use those influencing contextual factors I showed you to really promote learner development, moving from a rigid, more fixed nature to more contextual adaptation, more flexible and nuanced in their management. Thank you. I appreciate the time. Hopefully you found this helpful, and I'll hand it back over to the DDX team.
Great. Thank you so much, Dr. Parsons. And with that, I will hand it over to Dr. Ben Muller.
Awesome. Let me just pull up the slides here and I will share my screen. Amazing. So first of all, thank you, Andrew, for the awesome talk. Management reasoning, I think, is something that certainly, at least I didn't hear a lot about as a medical student or resident, and I think clearly something that has always been important, but increasingly so in the age of AI. Quickly, just about Sketchy before we dive into the exciting stuff, who we are and sort of what we do. So DDX it's an AI powered platform to teach and assess reasoning skills effectively and at scale. So I think both of those components are really important to us. We want to be evidence based and sort of create meaningful experiences, and we want to enable you as educators to do this in a way that sort of hasn't been possible in the past. At least for undergraduate students, we have a huge library of cases. We are rapidly building up our resident learner library as well. We can help you generate your own cases. We use multiple rubrics to evaluate those cases and sort of provide, again, that sort of meaningful feedback. And all of this, despite us existing in the age of AI, is built in collaboration with educators and practitioners. So everything is touched by human hands before it goes in front of learners. And so, we've got some of the awesome institutions we work with over there on the side, as well as an amazing group of collaborators. So in terms of how schools use DDX across the curriculum, I think, and sort of tying this to your talk, Andrew, there are three main ways that we think about this. The first is building those clinical foundations, and you have that great image in your slides of the gears. And I think those gears don't turn. If you know how gears work, and I don't really, but if you know how gears work, they don't turn unless they can all turn, right? And so starting with that sort of diagnostic picture and then moving up the steps of building your management scripts, adjusting to context, thinking about the patient and the situation. And so I think, we try and help at all stages of that, but particularly helping students develop their clinical reasoning, diagnostic reasoning abilities, and then helping them build those management scripts. And then I think, something important that you mentioned is your example of the two different patients, both with heart failure, who kind of have different life contexts despite kind of the same evidence base. And so talking to those patients is really important and eliciting from them what's important to them in their care. And so we have a number of communications cases, again, to help trainees and learners focus more on those aspects as well. So the second aspect I sort of alluded to already, but building those management scripts, helping learners just get practice, repetitive practice of working through cases across the clinical spectrum, but also, and I think this is, again, where scale comes into play, having the kind of unique experience, especially outside an immediate clinical context, of getting to try the same type of case, but not the exact same case over and over. So in your career, you'll see hundreds and hundreds, at least if you're an internal medicine doctor, you'll see hundreds of ACS cases. They're all similar, but they're all different as well. And so giving students that sort of mirror of, you're going to see a bunch of patients come in with chest pain. They're not all going to be the same, even if you maybe start thinking about them in the same way. And so giving them that opportunity. And then sort of tying back to one of the first, maybe your first slide, you mentioned cognitive offloading, or I've heard the maybe sort of more poetic term cognitive surrender, which is a little frightening sounding. As these tools become prevalent in practice, how do we think critically about the output of those tools? How do we make sure that our learners and our trainees are equipped with the requisite base knowledge to evaluate the output of those tools? And so I think those are kind of two sides of the same coin. when we invented the calculator, we didn't stop teaching math because you need to make sure that you're getting the right output. Uh, and at the same time, how do you think about these tools? These are increasingly complicated tools. And so how do you remember effectively to evaluate the output that you're getting? I think you have a really nice picture for why diagnostic reasoning is similar to the way that these models work. But as you already know, and as everyone has seen, the models are coming for management as well. So I think being able to really effectively think about what the tool is telling you is really important, especially for trainees who don't necessarily have that basis of experience to go on. So I'll talk a little bit about kind of both sides of these. I want to show a quick demo of one way that we think about management reasoning here at Sketchy, and then I want to show a little bit about the AI readiness element as well. So this is a patient admitted for a pulmonary embolism. What you're looking at right now is the faculty view. So what you would see as an educator before you assign a case to a learner, and you can see the learning objectives and sort of the whole details of the case. Normally, what I say when I'm showing this screen is, and you can also see the diagnosis, which obviously the learner can't see. But in this case, it's right up front, right? So before you even start the case, you're told that CTA shows a saddle pulmonary embolism. This is not your send them home PE patient from your example, Andrew. But so clearly we're sort of moving a little bit past diagnostic reasoning here. And we don't need to go through all the details here, but you've given some chart review again, just like a resident in the hospital would do, quickly review the ED note or whatever it is, whatever they have available to them before they go think about how to care for this patient. Uh, each of these interactions is modeled as a conversation with the attending physician. I'm actually going to skip past this one. This one is sort of getting at multidisciplinary care and getting that PESI score that you mentioned, Andrew. Um, let's get this multiple choice question too, but I want to get into this, right? So one of the things that you were talking about was one, residents or learners having the phenotypes of where they sort of break down. And I think the number two was how do they respond to updated or changing situations, right? Do they have the management script and then can they evolve with the patient? And so here you're given some data about, okay, you've done all this stuff for the patient already, based on that evidence that you were talking about. It's not working. The patient is still deteriorating. The situation is evolving. How do you respond to that? So, blood pressure is dropping despite pretty significant interventions here. So what do you do next? I'm a simple urine doctor, so this is not my area of specialty. But let's get them a central line. And so as you work through this situation with your attending, they'll kind of give you some feedback and help you think through the case. So I am a simple urine doctor. I also have access to the DDX backend, so I can cheat and say that let's get this patient some diuresis, pulmonary vasodilators, type. Let's increase their pressors and add inotrope, which is a word I haven't thought of in a long time. So doing all the right stuff for this patient, again, based on their deteriorating clinical situation. Let's push a little further. Great. He's in respiratory distress despite high flow. We need to think about intubating him, but what are the risks there, right? So how do you sort of dive into this management? How do you make it more nuanced? And then how do we mitigate the effects of those potential risks, right? So we're worried about circulatory collapse. What can we do with the vent to minimize that risk? My attendings would be so proud of me. So, again, just a quick example of getting into some nuanced management. And then, great, so we place that central line, we add some diuresis, we do all those interventions. Things look like maybe they're improving a little bit. Now what? What do we do now? And I think this kind of staged management or continuing to push through, right? As a medical student, you sort of have one answer. And here, as you move forward in your training, as you sort of move up the ladder of management reasoning, I think next steps and what's next, and sort of always considering what's coming down the road. So now we get into the OR finally. We can take this guy's embolism out. And then great, we can think about some ECMO too. So again, quick example of a place where I think we're moving past sort of basic diagnostic reasoning and really pushing into a more complex management type case. And so then we finish with some teaching points and sort of the rest of the patient story there. Um, and at the end of the case, and this may take a minute to generate, we'll get some feedback on how we did and how we performed. And I was sort of pretty brief and brusque in my answers there, but we'll get some kind of thought about what we're doing here, as well as being able to see what the steps for each of those areas was. So hopefully it gives you a sense of one way that we're addressing management reasoning. Again, I think there are lots of nuances to this, as Andrew mentioned. Communication, again, being a big part, which you didn't really see there, but that comes up in other cases. The other thing that I want to quickly do is show an example of how we're thinking about the cognitive surrender issue. And just, AI is a big topic everywhere. How are we thinking about the way that trainees are approaching that? And so I'm going to share a demo here. This is actually a video because the mic does not work super well on Zoom, but hopefully you'll get a sense of what we're working with here. And I'll add my notes as well as we're going through this. Hillary or Andrew, if you can let me know if the sound is working for you as we're going through the case.
Hi, I'm Lola Sanders. I've been having this really bad pain and swelling in my right leg. It's been worrying me a lot. Can you help me figure out what's going on?
Hi, Lola. I'm Dr. Muller. I'm really sorry to hear about your leg pain. Tell me when that started.
Thank you, doctor. It started about a week ago. At first, it was just a little pain in my right calf, but it's gotten worse, and now my leg is swollen too. It's really scary.
Was anything going on about a week ago when the pain started?
Well, I had just come back from a road trip with my friends. We did some hiking during the trip, and I thought maybe I bumped my leg or slept funny, but it just kept getting worse instead of better. And now I'm really worried about it.
Was it a long road trip you were on?
Yes, it was quite long. We drove all the way from New York to California. It was really fun. I love traveling and hiking with my friends. That's why I'm so eager to get this leg pain sorted out before our next trip.
Does anything seem to make the pain better or worse?
I tried elevating my leg to see if that would help with the swelling, but it didn't really get any better. Taking Tylenol helps a little with the pain, but only just a bit. The pain still feels pretty bad, like a 7 out of 10. It makes me really sad and anxious.
How about any chest pain or shortness of breath?
No, I haven't had any chest pain or trouble breathing. It's just my leg that's bothering me.
Okay, and do you take any medications?
Yes, I take oral contraceptives. Other than that, no regular medications.
And how about cigarettes? Do you smoke cigarettes?
No, I don't smoke cigarettes. I do sometimes use marijuana when I'm with my friends, though.
So continuing with our DVT PE theme here, hopefully you got a picture of her case. And while there's not direct management involved in that conversation, I think quickly we get into management reasoning components. So here's a note that was generated by an AI scribe. And this is sort of really coming to the real world soon. Abridge just announced that they're adding clinical decision support to their AI tools. And so the output here was about cellulitis, which, isn't sort of the picture that we got from the patient. What do we want to do for her? How do we think about that? How do we evaluate these tools? So went through the note quickly and updated that. And then what the learner sees here is essentially some feedback on their evaluation of the AI generated note. So great. We recognize that it caught that it was telling us to do manage cellulitis instead of DVT. But we missed that it added this whole objective section about a physical exam that clearly I didn't perform. Um, so again, just building tools that help fight back against that cognitive surrender, that cognitive offloading, and remind trainees in the same way that my attendings told me to fold the top of the EKG over and disregard the machine read. How can we build confidence in trainees' own ability to evaluate these things and build a healthy skepticism of what the AI outputs are? So with that, I will stop here and open it up for questions. Just want to say once again, thank you so much, Andrew, for an awesome presentation.
All right, thank you, Ben. And just quickly, before we move on to the questions portion, if you're interested in seeing firsthand how DDX can support your learners and your program, we invite you to sign up for a free trial. The QR code will also be on the questions slide too. But you can scan the QR code to get instant access, explore up to 6 cases. In addition to trying our custom case generator, you'll also have the opportunity to explore DDX's reporting tools. And I'll also be sharing the link in a follow-up email over the next day or so, also including the recording and slides to this presentation. And quickly, one last note on DDX. We are going to be attending a number of events over the next week. So we'll be at ACP, AAIM, ACOM, and SIEM, and we'd love to connect with you in person. So you can stop by the DDX booth to see how the platform supports clinical readiness and curriculum goals, and talk through how your program is approaching AI integration. And if you won't be there, you can also schedule some time directly with our CEO, Garish. He'd be happy to walk you through DDX and explore how it could support your program over a Zoom call. You can scan the QR code on the screen and find a time that works for you, or I'll also be sharing this link in the email follow-up as well. And with that, we have about 7 minutes to get to the question portion. So please ask any questions that you have in the Q&A feature. The first one is, thank you, Dr. Parson, for this wonderful presentation and reframing regarding concerns, fears about AI. Your data was framed around GME. I recognize the arc of education and level appropriateness, but wonder if the optimal time to teach or think about this is in the clerkship years. Any thoughts on that?
Yes, thank you. So I absolutely agree. I focused on GME because that's where my research lies more. But I think that I'm of the opinion that both management reasoning and diagnostic reasoning, or clinical reasoning overall, we should start teaching from day one. I think of it as providing kind of a framework or a scaffold of the process, and then as our learners are building up their knowledge, it's kind of filling that bucket. But they always have that process or that as a scaffolding to rehearse and practice over and over again. So I do think we probably still want to teach diagnostic reasoning first, but I agree. And there's been some good research on the clerkship year and what students are actually experiencing. And it's much more management than it is diagnosis. And so even though our pre-clerkship may be knowledge focused and to some degree diagnostic reasoning in our clinical skills courses or our doctoring courses, when they're actually thrown into the clinical environment, it's what do you want to do for this patient? And I think they don't have a framework to do that. And so I think we could use the management script, the process that Ben highlighted there, the illness specific nature, the context specific nature, and start with that framework from day one, so they have a process for proposing plans.
Great, thank you. And the next question is, do you see AI management and diagnoses being perhaps different, more or less useful in psychiatry?
Oh, interesting. In psychiatry, um, I'm not a psychiatrist, of course. I mean, I think for the reasons I mentioned, I think AI will, I'm not one that thinks AI will truly replace us, displace us. I do think that we will continue to partner with AI, and it will probably play quite a prominent role on the diagnostic side. And as Ben mentioned, it's coming from management too. So I think on the management side as well, but it will probably, at least initially in the short term, do a very good job of giving us the most evidence-based answer, right? So here's the diagnosis, here's what we're concerned about. Let's say from a psychiatric perspective, here's what we're concerned is going on. Propose a plan to me, and that would be a very evidence-based plan. But I think you have to then take that plan and tailor it to the individual patient in front of you. And then there's negotiation, there's all kinds of communication that has to occur from there. So that's kind of the way I see it going. And so that's why I think we really have to upskill that component and start teaching that earlier, not just rely on kind of role modeling like we do now to learn that ability.
Got it. Thank you. And one question from the chat that I saw, I like that the software challenges the learner to identify incorrect details in the note. However, I would love to see the software require the learner to identify elements of the case that influence their management reasoning, i.e., requires active engagement of the learner, not passive observation. Is this a feature of the program? That's for you, Ben.
Yeah, great question. Absolutely. I think you didn't see it in the case that I just demoed, but we certainly have places where we ask the learner to reflect. That almost question exactly as written is one of those questions. So what sort of elements of the case influenced your thinking about this case, whether management or other aspects of it? So certainly an aspect of the program.
Great. Thank you, Ben. And I just saw, can you also email us prior descaling AI DDS webinar? Yes, I made a note, Anna, and I will send that over to you following the event. Next question is, we have a lot of resources these days for learning diagnostic reasoning. Any JM cases, clinical problem solvers podcasts come to mind, but not much that I'm aware of to learn management reasoning. Do you have any recommendations for such resources?
Yes, but I mean, I agree. Relatively speaking, there's much less. And so most of the research over the past decade or so, less than a decade, has been focused on defining the process, right? I'm focused on the development, like how do learners develop this ability? And so then I think that the next step is how does that inform teaching and assessment? But there are 3 to 4 good resources out there that maybe I can send to Hillary and she could send out with the slides when that goes out, if that works.
Yeah, I'd be happy to do that.
Okay, great.
Okay. What is your preferred LLM AI tool for a diagnosis that you point learners to? And at what stage of the education training do you recommend introducing AI tools, i.e., UME, intern, etc.?
This is for me.
I think it
Um,
is for you.
yeah,
Yes. Sorry.
sounds good. I mean, I like open evidence. I've seen it be wrong a number of times, but I think for clinical decision support, like it in the clerkship year, especially for residents, I like open evidence relative to up to date. Although I think up to date's coming out with an AI backed program. I like Claude personally for just day-to-day productivity and work related things. This is less clinical, but just for helping educators create different things, Claude is really good. I think it's surpassed GPT, but that's just my opinion. Um, and then I mean I see both sides of this. Some people think we need to wait on AI integration because of the descaling issue or the never scaling, a more appropriate way of saying it. But I think that ignores the fact that our learners are using it anyway. My daughter's 11. She like comes home and says things about ChatGPT. So I think if we were to say you're not using it for the first year, I think they're just using it in ways that are less regulated, less informed. So I think we have to introduce it in a staged way and explain to our learners this is how we are teaching you to use AI and we want you to develop the skills in the clinical reasoning skills in parallel. And so I think we have to introduce it right away, but use it. I like to use it as a consult, right? So first you're going through your own process, building a differential, thinking through management, and then ask AI, what have I missed in this situation? Allow it to fill in the gaps, reflect, and then you can, repeat that process over time.
Great. Makes sense. Thank you. And the final question, if we have an extra minute, human factors psychologists, med school professors here, have you considered other models of decision making besides those, such as the dual process model described in the judgment and decision making literature, naturalistic decision making, macro cognition, data frame model of sense making as a possible theory for management reasoning?
No, so some of those, yes. So dual process very much influences my thinking, our thinking on this. and then situativity theories, which I didn't go into today, but is very much a focus. So like distributed cognition and situated cognition and ecological psychology, those type of things. But some of those that you said I'm not familiar with. So feel free to reach out to me. I mean, would love to hear more about that.
Thank you. And with that, we're at time. So thank you both for such a great discussion. I saw in the chat that, yeah, it was very helpful for many folks attending. So thank you all for joining us today too. We appreciate your time and engagement and hope this session gave you a helpful way to think about teaching and assessing patient management. As a reminder, you'll receive the recording of the session as well as the slides and the resources that we mentioned throughout the presentation. If you have any follow-up questions or would like to continue the conversation, we'd love to connect. Thanks again, and we hope to see you at future sessions. Thanks.